Can you say her last name? No. So our next speaker is Emily Saludacek. And see, I was like, that's what I'm doing. So I always talk about corrupting youth. And Emily started as an intern at Duke 15Q Alliance 2 years ago, maybe a little bit more. And now has become a certified genetic counselor. And we're so proud of her. So she's at the Baylor College of Medicine, but as part of her dissertation, she did a study on understanding your genetic report and what that means for your anxiety and understanding all those things. So I'll hand it over to Emily.
All right, so I am joining you guys virtually. Unfortunately, I am still stuck here down in Houston. Is someone able to let me know if you guys are able to hear me correctly?
We can hear you. Yes, everything
Okay.
Sounds great.
Perfect, thank you. So I'm going to go ahead and start sharing my screen here.
Perfect,
so
and we can see that.
Are you able to see the screen?
We are, yes.
Great, thank you so much. So as Vanessa said, my name is Emily Saludacek. I am now a genetic counselor. And during my training, in order to become a genetic counselor, I decided to help give back to the Duke 15Q community by spending my master's thesis studying the psychosocial or emotional outcomes that parents experience after learning about their child's diagnosis. And so the title of my study was called An Exploratory Study of the Genetic Knowledge, Diagnostic Experiences, and Emotional Outcomes of Parents with Children Diagnosed with Duke 15Q. And now, while this study specifically surveyed parents of children with Duke 15Q, I think that some of the conclusions of the study can be more broadly applied to some of the other groups that are joining us here today, such as the 8P and the Ring 14. But we'll be able to talk about what that looks like towards the end. And so the overall purpose of this study was to identify gaps in diagnostic counseling by investigating differences in genetic knowledge and the emotional outcomes of parents of children with genetic syndromes, and for this one specifically, Duke 15Q. Through our background research, while we were developing this study, we know that psychosocial outcomes and a parent's ability to cope with their child's diagnosis is influenced by a variety of factors. One of which being the genetic knowledge surrounding the diagnosis that the parent possesses, the diagnostic experience that the family goes through, and the psychosocial support that the family receives. When we break down these different experiences, such as the genetic knowledge, we know that that's also complicated by complicated medical management. So the amount of genetic knowledge that parents have or retain can be influenced by almost an information overload, which is oftentimes something that happens when your child has a complicated medical diagnosis. And this complicated medical diagnosis can also increase psychosocial distress within families. And whenever I say psychosocial, that usually just means emotional outcomes, or as Vanessa mentioned earlier, anxieties. We also know that about 50% of any information retained in any type of medical setting is actually accurate. And only when surveyed following a doctor's visit, only about 20% of information is actually even retained. So in total, about 10% of what parents learn in counseling sessions or just seeing a doctor is actually accurate when they're asked to repeat it later on. And because of this low retention, we know that parents are going to the internet more often to find information surrounding their child's diagnosis. And as I'm sure you guys have all experienced, the internet is not always the most accurate place for this information. When we talk about diagnostic experience, a couple different things go into this, such as the length of the diagnostic journey or how long it took you to receive a diagnosis for your child, the actual result disclosure, so the counseling that you received and the provider knowledge that that provider actually had. We also know that when we talk about copy number variants or differences in larger pieces of chromosomes, the type of duplication or deletion has an influence, as well as whether or not the genetic diagnosis was inherited or de novo or new in the child. We know that the parent's ability to cope with their child's diagnosis is decreased when they have a negative results disclosure experience. It's also decreased when the genetic disorder is considered to be inherited. When we think about psychosocial support, many different articles have surveyed parents and what they felt that they needed following their child's diagnosis. Most of the time, this is split between informational needs and psychosocial needs, but the majority of it was parents were requesting more psychosocial support. This included support when it comes to confronting the guilt they felt surrounding their diagnosis, as well as general support from healthcare providers, including more empathetic responses and support resources. So being able to connect families with support groups and advocacy groups, such as the ones that are hosting this conference today. So more specifically, our project aimed to describe the parental knowledge of inheritance patterns and reproductive risks of Dupe 15q, as well as describing the guilt and blame experienced among these parents. We went about this, as some within the community might remember, through a survey that was sent out. Our data collection period lasted from September of 2020 to March of 2021. So it is important to note that this did go through the period of COVID. All of our data was de-identified, so none of the responses can be linked back to the participants. And our surveys were conducted on an online platform through Baylor. Our inclusion criteria included the biological parent of a child with Dupe 15q. We did require the parent to be biological, simply because we were going to be asking about guilt and blame associated with inherited Dupe 15q or also reproductive risks. And in order to get an accurate representation of that, the parent would have to be the biological parent. We also asked that our participants were English speaking, simply due to funding for this project, that they were legal adults, and that the child was molecularly diagnosed with Dupe 15q within the past 5 years. And that 5-year cap was really put on there just to help compensate for the changes in genetic testing and the advancements, and hopefully have most of the families included had the same type of genetic testing. We recruited from the Dupe 15q Alliance using their research registry called the Ladder, which is short for Linking Angelman and Dupe 15q Data for Expanded Research. And this was all managed by RTI, which is an independent research management company. You heard me throw around the word diagnostic experience or diagnostic journey earlier in this talk. And the way to we really broke this down within our survey is we wanted to know what was the provider's specialty for the provider who ordered the genetic testing for the child, or who also counseled on the results. And that's because we wanted to really separate out whether or not families were seeing genetics providers or if they were seeing other specialties. We also wanted to know whether or not the parents actually had counseling regarding their child's diagnosis, whether or not it was an interstitial or isodicentric duplication, whether or not it was maternally or paternally inherited, and whether or not the parents found out if it was inherited or de novo. And for the purpose of this study, we did define what counseling actually meant, because we know that not everyone gets access to something such as a genetic counselor in their diagnostic journey. And so for the purpose of this study, counseling was a conversation in which a healthcare or support group professional spoke to the parents about their child's diagnosis. The conversation often involves information about the symptoms associated with the diagnosis, the genetic inheritance pattern, medical management, and also recurrence risk for future children. And so in order to gather parental genetic knowledge, we asked a variety of questions that focused on basic genetic concepts or just generalized genetic concepts, as well as questions more specific to Dupe 15q, such as recurrence risk questions. So things that might change between different disorders, but we wanted to really make sure that the parents had an understanding of their child's specific genetic diagnosis. And so this is just an example of some of the questions that we asked, such as, are all serious diseases inherited? Do parents pass both or one copy of each chromosome to their child? Can healthy parents have a child with an inherited disease, and so on and so forth. Again, we asked about the very specific recurrence risks for Dupe 15q. So what was the chance of them having another child, their child having a child with Dupe 15q, or an unaffected sibling having a child with Dupe 15q? It is important to note that we did specify through skip logic, if the child had an inherited or de novo form of Dupe 15q, because we do understand that that does change the numbers for some of these families and how they would answer. And we took all the answers to these questions and we calculated out as either low or high genetic knowledge. And this is not a hard or fast, whether or not a parent actually has good or bad genetic knowledge, just what we use for statistics. And we decided that an answer, 9 out of the 11 correct answers would result in high knowledge, whereas anything less than 9 correct answers out of 11 would result in low knowledge. We surveyed emotional outcomes on scales. So an example would be, we asked parents about guilt. So we said that sometimes parents feel guilty about a child's illness. Then we asked how guilty that parent felt about their child having their genetic diagnosis. And parents were able to answer on a scale of 0 from not guilty at all to 5 extremely guilty. We asked similar questions for any blame that parents may have placed on themselves in the past, as well as any blame that they might have placed on a partner, so the other biological parent of the child in the past. For all of the blame questions, we also asked how they felt currently, so whether or not they were currently placing blame on either themselves or their partner, and also whether or not they felt as if their partner had placed any blame on them in the past. So here's where we ask the current blame placing. And the way that we dealt with this data is we decided that a score of 3 or above, so if someone had selected a 3, 4, or 5, we assessed them to having experienced significant emotional outcomes, so whatever that emotional outcome was, whether or not it was guilt or blame, anything less than a 3 being less significant emotional outcomes. So understanding that there still is an emotional response, but just for statistical purposes, 3 to 5 was considered more significant. And so what we were able to find after everyone took our survey for us, so we did end up sending out around 450 surveys, and we got 29 total responses that we were able to fully analyze, which resulted in a response rate of 6.3%. We were able to grab a lot of demographic data. We had a fairly good spread in parental age, which we were happy with, as well as an educational spread, although I will comment that most of our respondents tended to have advanced or higher levels of education. And we were able to actually survey parents from all different types of locations across the United States, so urban through rural. When we asked parents who they're ordering, so their genetic testing ordering provider was, we actually found that the majority of our respondents, so 31%, had their genetic testing ordered by a neurologist, which is not surprising, as I'm sure many of you know that some of the first manifestations of Dup15q might be seizures or autism spectrum disorder. But we were happy to see that the next largest piece of the pie was actually 24%. So if you were to lump genetic counselors and geneticists together, 24% of our population saw a genetics provider as their ordering provider. And so we were surprised because even though a majority of our population saw a neurologist first, for those who did receive diagnosis counseling, actually all of our participants had received that counseling from a genetics provider. So whether it be a geneticist on their own, a genetic counselor on their own, or the two combined. We found that not everyone did actually receive such counseling, so only about 55% did. And those who did receive counseling, a majority of our participants received it within a few weeks, although we do know that some individuals have to wait sometimes up to more than a year. We were also surprised to find that most of these children were actually diagnosed greater than 3 years of age. And I think that says a lot about just the access to genetic testing and access to providers who are ordering the right test and recognizing the right signs and symptoms. Oops, sorry. We did find that about 17% of our population had an inherited form of Dup15q, whereas majority of our population their child had a de novo form, which is not surprising because as the speaker before me mentioned, the more common form of Dup15q is going to be the isodicentric, and therefore the de novo form, or the form that's new in the child. And again, when we lumped the unknown, we actually, for parents who responded as unknown, we went with the most likely cause of Dup15q being the isodicentric or the de novo form, making our inherited 17% and our de novo 83%. When we looked at parental genetic knowledge, we found that a majority of our population, about 72%, had what we classified as low genetic knowledge. We also found that you'll see over the course of the results, when it comes to emotional outcomes, parents were more likely to place an emotional outcome of guilt or blame on themselves than they were to place on their partner. And so you can see it here in these two graphs, the one in the middle and the one on the right. 66% of our population experienced guilt, significant guilt, whereas only 10% reported that they placed a significant amount of blame on their partner. And then when we look into the different subtypes of self-blame, so such as current and past, we found that again, more of our population placed blame on themselves than did not. But we also found out that when we asked parents to report the self-blame that they felt in the past versus currently, that these numbers went from 17 reporting self-blame to 12. And so we believe that that self-blame is decreasing over time, which could be due to a variety of factors. As you can see here, again, as I had mentioned before, most people did not report that they felt as if their partner had placed blame on them in the past. But then also that those who did report it was 6, and then did also decline over time. Again, I think we are assuming that blame felt by parents is higher at the time of diagnosis than it is after being able to cope with that diagnosis. When we looked at the mean guilt, so the just average numbers of the guilt and the blame experienced by parents, we found some very general trends. Most significantly, we found that those reported to have high knowledge were significantly less likely to experience the emotional outcomes, or they reported significantly less feelings of these emotional outcomes. As well, those with a child with the inherited form of Dup15q were more likely to feel a greater amount of the emotional outcome, as well as fathers. And you can see this trend continuing over the different types of emotional outcomes. So as well as self-blame in the past, self-blame currently, partner blame in the past, partner blame currently. And then again, we think it's due to the fact that the amount of participants who experienced blame placed on them by their partner was switched. So that was something that most of our participants did not really report to have significantly felt. A lot of these numbers actually flip-flopped with that answer. And so one of our biggest questions are diagnostic experiences, or the amount of parental genetic knowledge that parents contain significant indicators of emotional outcomes felt by parents of children with genetic diagnoses. And so through our study, we found that as genetic knowledge of parents increases, most significantly, the amount of guilt that they feel following the diagnosis decreases. And so, in a numbers term, those with high genetic knowledge had 92% lower odds of feeling guilty compared to those with low knowledge. We attribute this to having a better understanding of the diagnosis. And that's mostly because, as we know in Dup15q, it's much more likely to be de novo and not, it's never something due to the parent's fault. But we would hope that by understanding the diagnosis and understanding that this is not your fault as a parent, that your guilt would be reduced. And so we know that low genetic knowledge regarding recurrence risk, the mode of inheritance, and the natural history of the disease could be linked to retention. And so as we talked about before in the background, we know that retention just in any doctor's visit is low, and accurate retention is even lower. And we did see that reflected in our study population. We also know that parents felt significant amounts of guilt and blame. This might be due to the inability to answer recurrence risks, which again might be linked just to that retention and the amount of information being shared at a diagnostic counseling session. We also questioned whether or not parental research following a session is leading to false information. We know that having this false information and having these increased emotional outcomes can lead to increased incorrect recurrence risk, and which can influence family planning and whether or not families choose to have more children because they may or may not be afraid of the same genetic diagnosis happening in a new child. It can also lead to incorrect assumptions about the inheritance pattern and therefore disrupt the family structure. As an example of this might be a partner placing blame on the other. Just, hearing that something is maternal or paternal, it might lead to assumptions. And also we know that overall decreased knowledge increases emotional outcomes, which are never something that we want parents to experience following a child's diagnosis, although it is, I think, unavoidable. So at the time of diagnosis, we know that parents want thorough disease education. They want to be as involved as they can. They want to know everything and be able to take care of their child the best they can. I think probably many people have mentioned it before me today, but parents do end up becoming the experts, even though some of us are trained in genetics, but it's something that happens over time. And so we ask ourselves, is guilt and blame placed on oneself, even when it's not necessarily warranted? Is that a coping mechanism that parents are experiencing? And also some things that might influence increased emotional outcomes are delays in diagnosis and the anxiety that comes along with waiting for your child to get a diagnosis. Parents are obviously very worried when their child's having symptoms, and really being able to find a provider to be able to listen to you, and then just the amount of time that genetic testing can sometimes take. We also know that there might be a lack of psychosocial support that parents are receiving, and that can be peer support, so such as being connected with other families who may have the same genetic diagnosis, or just empathetic responses and support from their providers as well. We know that increased emotional outcomes can lead to mental health concerns in parents, which may also lead to physical well-being concerns, feelings of hopelessness and helplessness, and reduced family structure. So in very severe situations, it may lead to depression, which can lead to less effective parenting, or a parent feeling hopeless and helpless and not feeling as if they can actually care for their child. And so overall, these are obviously not outcomes that we want parents to experience. And so the goal that we came up with following this study is that we need to increase the genetic knowledge of parents in order to decrease feelings of guilt and blame. So we know that the ability to retain information is a linear function of the amount of information given. And so what we proposed following the study is that in order to decrease the amount of people who had low genetic knowledge or increase the amount who have high genetic knowledge, we need to increase the provider knowledge of the disorder, and also possibly implement continued counseling and genetic education past just the diagnosis. And so making sure that providers are giving accurate and compassionate information, as well as repeating this information over multiple visits so that parents are not overwhelmed. In order to address the guilt that parents have experienced, we would like providers to provide appropriate empathy and psychosocial support. So making sure that providers are educated in which support groups are out there, which support groups are appropriate for families, as well as being empathetic in their delivery of a diagnosis. And because we found that blame was decreased over time, we suggest that more time to process their child's diagnosis and also improve retention of genetic information would lead to a reduction in psychosocial stress and better coping for parents. So a combination of continued education over time and provider empathy and support would lead to emotional outcomes decreasing in parents of children with a genetic diagnosis. And so overall, just in conclusion, we found that parents with high genetic knowledge experience less emotional outcomes of guilt and self-blame than parents who had low genetic knowledge. And also that additional psychosocial and informational support is needed to help enhance parental knowledge during diagnostic counseling or when families receive a diagnosis in order to help reduce parental feelings of guilt and blame. And we hope that the application to providers is that this highlights the importance of information giving and education during the diagnostic counseling sessions, as well as making sure that there's not an information overload. It proposes a need for continued genetic education of parents, as well as highlights the need for additional psychosocial support for families. Overall, I'd like to thank everyone with the Duke 15Q Alliance, especially the families who took time out of their day in the very busy COVID world to participate in our survey, as well as the advocacy group for allowing me to use their research registry, as well as my genetic counseling program for allowing me to give back to this community. And if anyone has any questions, I'd be happy to take them.
So we have one question, but I think, Charles, I think it was answered in there, so I won't ask it. But I think, one, great presentation, and I'm also a two, very, very proud of you. I just feel I'm having a real mom moment here. I think we've talked about this, you and I, but I kind of want to have you guys address this to the group. We talk a lot about this being kind of on parent knowledge and that sort of thing. And you did quickly talk about the provider aspect of this, but can you kind of unpack that a little bit more in these areas where you could see actually in clinic when these families go in and they get their genetic counseling, or they're seeing their geneticist, or getting that piece of paper that says this life-altering thing? What kind of ideas do you have that we can really apply this that will allay that guilt and blame and that anxiety around that diagnosis?
Yeah, I think there's a really great answer if the world was perfect. And I think that would be, greater increase to genetic services and having providers who are trained and specialized in these areas. But I also think, just going back to the tail end of the talk before me that I caught, and talking about things like balanced translocations and some of the questions that parents had about, being confident in whether or not something is inherited or de novo. So being able to educate providers is where to find the information in order to have accurate testing and complete testing, especially for chromosomal abnormalities, where you can have things such as translocations and methylation differences, and making sure that families are getting this comprehensive care and that providers know where to find it or know who to refer to. But also just making providers more aware that genetic services are out there, because I think that it's really something that's increased over these past couple of years and not everybody knows about it.
Any other thoughts? So I actually, when she was bringing this to us and saying like, this is what we want to ask questions about, I thought it was really, really a great start. I mean, honestly, this is a start, right? This kind of dedication, this kind of research needs to be done in kind of every rare disease, because I think that journey that you kind of get there, how everything gets there, and everybody's experience is a little bit different, but everybody's experience is traumatic is really important to get down on paper. How to improve it is that's the only way it's going to happen. So is there any other questions, or just? Okay, so we are going to head to a